All right, hi everyone. Back today with just another video of quick amount of kodachromes to roll through. I thought the interesting twist on today's video would be that these kodachromes are all derived from our outpatient teledermatology program. So me and one other attending here do outpatient or e-consult, teledermatology consults for Ohio State Medical Systems. And I thought it was interesting to just include four cool and pretty pathognomonic kodachromes for your review today. So you get to kind of learn about these conditions, but also see these photos in real world situations. So these are how either the referring physician sent them in or how the patient sent them to the referred physician and then forwarded it on to us. So as always, when you see the case, I want you to pause the video and take a second to think about what you think this is. Have your first gut impression and then put a reaction pattern to what you see and see if those two things match up. For these entities that I'm about to present, they're pretty pathognomonic, so I'm just going to go through them based on kind of clinical and regional findings that you see rather than reaction patterns like I've done in some other videos. So the first case was for this lesion on the finger, and so the e-consult came in that the patient was concerned about this lesion in their finger, and what are you noticing here? So multiple things. So just distal to the distal interphalangeal joint, you have this kind of dome-shaped papilonodule, a little bit translucent, almost like a little central dell or umbilication. But interestingly, and not noted in the referral, but something I want you to pick up on as dermatologists or future dermatologists, is the resulting distal nail changes that you see. So you have this lesion here. It's located laterally, so off the midline, just distal to the DIP. And what are you seeing here? And the nail, the actual nail plate, you're seeing lateral nail dystrophy. So normal nail here, dystrophic kind of indented nail here. And that's not coincidental. As you can imagine, this is laterally located and this mass is laterally located as well. And so that makes this lesion most likely a digital mucus cyst, or better names a digital mucus pseudocyst, because it's not truly a cyst because it doesn't have an epithelial lining. Instead, what this is a collection of myxoid tissue or mucin that's extravasated from an underlying osteoarthritic joint. So due to wear and tear, where bone meets bone here, they're encapsulated by a joint space. There's tearing of that joint space. The mucin links superiorly, pushes up through the skin and gives you this dome-shaped papilonodule, this digital mucus pseudocyst. And what happens is, due to the pressure of that mucin over time sitting on the proximal nail matrix here, you get dorsal nail plate dystrophy in line with where the lesion is. So if the lesion is midline, you'll see midline dystrophy. If it's lateral, you'll see lateral dystrophy. So one of the good kind of keys for making the diagnosis in this case is that lateral nail dystrophy here. So if you have a translucent papilonodule between the distal interphalangeal joint and the proximal nail fold with resulting dystrophy, you want to think about digital mucus pseudocyst as the best diagnosis. This is going to be best managed by a hand surgeon who will resect the lesion and then resect the stalk that communicates between the joint and the actual mucinous lesion. Next case was sent in. This patient is complaining of itching on their back. And what's interesting here, you actually get to see some pathology. A lot of time in dermatology, when we have the complaint of pruritus, there's actually no rash and you have a normal skin exam. But in this case, you do actually see some pathology here. So here's the spine. This is paraspinal. So paraspinally, you have a well-demarcated pink to brown geometric patch. And so if you have an itchy patch on the back that's paraspinal, geometric, red to brown, that's pathognomonic for this condition known as notalgia paresthetica. Now, notalgia paresthetica exists in a spectrum of conditions where it's thought to be due to dysfunction of cutaneous nerves, which causes localized itching, which leads to scratching by the patient, which leads to keratinocytes necrosing, dropping their pigment, leading to the pigment incontinence. So it's not like the condition here is causing the primary hyperpigmentation of the skin. It's the itching, which leads to the scratching, which causes macular amyloidosis or the keratinocyte deposition within the skin. So in the back, due to compression of nerves coming out of the spine due to degenerative disc disease or degenerative spinal disease, we call it notalgia paresthetica. When it's on the front, along the lateral thigh, due to compression of one of the cutaneous nerves of the thigh, we call it meralgia paresthetica. It's all the same thing. It's just different names and slightly different presentations that you have here. So this is notalgia paresthetica, really classic presentation. Because it's due to neuropathy or nerve dysfunction, you try to treat it with medicines that are aimed at treating the nerve. So you can use things like topical gabapentin or even systemic gabapentin, topical capsaicin, which is derived from these red peppers and decreases substance P, can be used as well. In general, though, this is not an easy condition to treat. This case I thought was kind of cool. I do like this in the scope of dermatology because it's just a reminder that despite the name dermatology or the study of skin, we also are experts and manage hair, nails, and mucosa, and we get called on in those areas multiple times because we're really the medical, kind of the medical dermatologists, the medical quarterbacks for those different conditions. So this is actually a tongue. So we're looking at the ventral aspect of the tongue. The patient's kind of putting it to the roof of their mouth and exposing the ventral aspect here. And what they're complaining out of is this acute presentation of this firm nodule at the ventral aspect of their tongue. Occurred within the last week or so. It's completely painless, but the patient's just worried about it. And so this is kind of an interesting phenomenon. And again, to know pathology, to know what's wrong, you have to know anatomy. You have to know what's right, what's normal. And so, it's something that I suggest if you're looking to become a dermatologist, you review hair, nails, mucosa, because those are areas within our purview. The tongue as well, even though it's tricky and things can appear different, again, within our purview. And so within the ventral aspect of the tongue, knowing a little bit of the anatomy here, this is the ventral aspect of the tongue, this is the frenulum. At the inferior aspect is actually a couple openings of the minor salivary gland. So that's usually where you have a normal secretion of saliva that flows inferiorly and then kind of goes up superiorly and bathes the ventral and then dorsal aspect of the tongue. So knowing that you have normal outlets here for saliva, if you get this sudden onset of almost a rock-like or very firm-like structure here where those areas form, you can imagine that this could represent a blockage of the saliva, and this is called a sialolith. And basically what happens here is if the outlets, for whatever reason, are plugged, saliva cannot exit those areas, and so instead it just pulls and pulls and pulls and forms this little plug. So it's helpful to know the acute onset's a key to differentiate it from something dangerous like a cancer, and usually treatment with firm massage is enough to just kind of push this out of those outlets and open those openings such that you get spontaneous drainage. Last case is a cutesy one. I just think this is a fun case because it's one of those examples of, where a dermatologist can kind of function as, a wizard, just kind of being a little clever and looking at cutaneous morphology and being able to predict something about the patient or the patient's history. So what you're seeing here are these kind of linear to quasi-linear, almost arcuate, hyperpigmented streaks on the dorsal fingers of this patient. This is another finding where this is just pathognomonic. The brownness here that you're seeing is most likely post-inflammatory hyperpigmentation, but the linear to arcuate streaks almost certainly tells you that this is an outside job, that this wasn't created by something intrinsic, not a primary dermatosis, but instead something that touched the skin and then in its wake or in its leaving led to this hyperpigmentation. And this is very pathognomonic for phytophotodermatitis. So phyto means plant, photo means light, dermatitis means rash. Basically, this is a combination of exposure to furocoumarin or a topical photosensitizer, which then in the presence usually of UVA light leads to a phototoxic eruption, kind of like an exaggerated sunburn. So it leads to erythema, vesicles. They're classically linear, almost like Blaschke linear, not truly along Blaschke lines, but kind of looking that way because of the exposure distally to one of those agents, classically like lemons or limes or things like that. Especially in the summer, you're going to see a lot of it as people are vacationing. And so you can really kind of raise some eyebrows if you see this type of rash and you ask the patient if they've been, squeezing limes or lemons or had anything in their beer or things like that. You can really kind of surprise them and get to the accurate diagnosis. So those were just 4 quick hits that I saw on e-consults. I thought they would be interesting to save and share with you, given the appearance and the pathognomonic nature of them. So hopefully you like this video. If you did, please like and subscribe to the channel. I appreciate that.